Good morning, or to my Italian friends, attenzione. We'll go ahead and get started with the parathyroid session this morning. Thank you all for your attendance. I'm Brendan Stack from the University of Arkansas. I'm one of the moderators. My co-moderator will also introduce himself. Just as a bit of housekeeping, we've been asked by the meeting organizers to remind attendees that there are two exhibitor areas. There is an exhibitor area on this floor, which is -3, I believe, and then one floor above -2. And we were asked to encourage you to go to both floors and visit the exhibitors in those spaces. Well, let's go ahead and start our session this morning. It's my pleasure to introduce Dr. Jeffrey Thompson from the Mayo Clinic, what I like to call the Mother Mayo, the main Mayo Clinic in Rochester, Minnesota. And he will be starting off our session by reviewing the AAES Parathyroid Surgical Guidelines. Dr. Thompson.
Good morning. Thank you, Brendan. It's a real pleasure to be here. And what I'm going to do over the course of the next several minutes is talk about the recently published guidelines of the American Association of Endocrine Surgeons. I have nothing to disclose. This summary was published in JAMA Surgery in August of 2016, for those of you that wish a reference. The guidelines were primarily written for the practicing surgeon, and levels of evidence were determined using the 2010 College of Physicians grading system. Because of the constraints with time, I'm not going to review the current understanding of the epidemiology and pathogenesis of primary HPT, but rather move on to diagnosis and clinical manifestations and then examine indications for surgery. With regard to the diagnosis, hypercalcemic primary hyperparathyroidism requires the demonstration of multiple elevated serum calcium levels with an inappropriately high parathyroid hormone. Normal or elevated 24-hour urine calcium over creatinine, so-called calcium clearance, is also necessary. Now, there's another entity that we've been recognizing more and more in recent years, and that is normal calcemic primary hyperparathyroidism. And this is incompletely characterized variant, often confounded by the presence of vitamin D deficiency. And these patients have an inappropriately high PTH level with normal corrected and ionized serum calcium levels. And in these patients, other causes of secondary hyperparathyroidism need to be excluded. Now, with regard to initial biochemical evaluation, this should include a total serum calcium, as I've said, and parathyroid hormone level, a creatinine, 24-hour urine calcium, and 25-hydroxy vitamin D levels. Parathyroidectomy is indicated when the serum calcium level is greater than 1 milligram per deciliter above normal, regardless of whether or not symptoms are present or absent. Now, these are the typical features that we are all aware of associated with primary hyperparathyroidism. And these include osteoporosis, nephrolithiasis, which can be silent, GERD, peptic ulcer disease, pancreatitis, arthritis, bone pain and muscle pain, fatigue, disordered sleep and weakness, depression and anxiety, polyuria, nocturia, constipation, hypertension, cardiovascular disease, and hyperlipidemia, as well as erectile dysfunction and premature death. Now, the features that appear to be potentially cured with parathyroid surgery include those ones that are outlined there in green. Familial hypocalciuric hypercalcemia is seen in about 1 to 2% of patients that are being evaluated for hypercalcemia and elevated parathyroid hormone. In those that have failed parathyroidectomy, in that group of patients, 20% will turn out to have FHH. These patients have lifelong hypercalcemia from a shift in renal set point for calcium excretion. So they have a low urine calcium, typically less than 100, and their clearance is less than 0.01. These patients may have normal bone density, and the only morbidity is unnecessary parathyroid surgery. It's autosomal dominant inheritance, and one can screen for the calcium sensing receptor mutations when suspicious. Now, as far as indications for surgery, we follow along with the traditional objective criteria: the calcium greater than 1 milligram per deciliter above the upper limit of normal, fragility fractures, GFR less than 60 or urine calcium greater than 400 milligrams per deciliter in 24 hours, the presence or suspicion of renal stones, a DEXA bone density with a T-score less than 2.5, minus 2.5, and a diagnosis at age under 50. Therefore, the recommendation is that parathyroidectomy is indicated and is the preferred treatment for all patients with symptomatic primary hyperparathyroidism. Nobody disagrees with that. Parathyroidectomy is also indicated for objective evidence of renal involvement, including silent nephrolithiasis, nephrocalcinosis, hypercalciuria with increased stone risk, or impaired renal function. The definition of symptoms may now also include neurocognitive, psychiatric, sleep, and other manifestations that can include fibromyalgia, GE reflux, erectile dysfunction, and cardiovascular abnormalities. Although curing primary hyperparathyroidism does not really have much effect on hypertension, we've seen that left ventricular hypertrophy can improve after parathyroidectomy, and we also know that there's an increased incidence of MI, stroke, hypertension, heart failure, and diabetes in primary HPT. And several high-quality randomized trials have also shown that neurocognitive symptoms can improve with parathyroidectomy. So in asymptomatic primary HPT, abdominal imaging should be obtained for the detection of nephrocalcinosis or nephrolithiasis. Surgery is recommended for patients with cognitive and other neuropsychiatric symptoms that might be attributable to primary HPT. Parathyroidectomy can also be offered in patients with cardiovascular disease who might benefit from improvement and potential lessening of cardiovascular sequelae other than hypertension. The non-traditional features of primary HPT, including muscle weakness, functional capacity, and abnormal sleep, should also be considered in the decision for parathyroidectomy. The features of reflux and fibromyalgia may also be considered in the decision-making. Another important fact is that parathyroidectomy for primary hyperparathyroidism is clearly more cost-effective than either long-term observation or the use of medication such as Sensipar or Cinacalcet. Now let's move on to the three steps in the evaluation of primary HPT. One, you want to verify the biochemical diagnosis. Two, you want to determine whether the patient can safely tolerate surgery, and there are a few that do not. And finally, what does the imaging show? So we'll move on now to talk about pre- and intraoperative management. As far as imaging is obtained not to make the diagnosis, it's obtained after deciding to operate and is performed for operative planning. Imaging done at high-volume centers is more likely to be positive, and imaging is significantly less accurate in the setting of multiglandular disease. So patients with negative imaging, therefore, remain surgical candidates. Cervical ultrasonography is recommended, one, to localize a parathyroid adenoma or adenomas, and two, to assess concomitant thyroid pathology. An experienced clinician should help determine which type of imaging to use. This is an example of an ultrasound, a beautiful bean-shaped hypoechoic lesion with peripheral vascularity. This is different from a lymph node, which would have a central core of vascularity. All right. And this is the most common imaging study that we use at our institution, the Sestamibi parathyroid scan. We use a dual photon subtraction scan with planar oblique and SPECT imaging. And here you can see a beautiful example of a subtraction scan with a right-sided parathyroid adenoma. This is SPECT imaging demonstrating a mediastinal intrathymic parathyroid adenoma. This is an example of a previously failed operation that included a left lobectomy, and the failure was due to an unrecognized, undescended parathyroid gland in the carotid sheath. And here you can see the exploration through a lateral approach, showing you here a beautiful adenoma within the carotid sheath. This is the carotid artery. 4D CT scanning can also be helpful when other imaging modalities fail. And here you can see a previously operated patient that has a paraesophageal parathyroid adenoma. And when we went back in, we went through a lateral approach, removing the contents of the carotid sheath laterally and going deep along the prevertebral fascia to identify a classic parathyroid adenoma. And finally, we're now in the United States, we have the availability of 11 choline PET CT and PET MRI, which has shown us some excellent examples of imaging, positive imaging, where all other imaging studies have been negative. The incidence of concomitant thyroid disease requiring management is about 40%, and that's why we in the guidelines recommend getting an ultrasound on every single patient with primary hyperparathyroidism. And here's an example of a patient that has primary hyperparathyroidism but also has a papillary thyroid carcinoma. So with regard to preoperative management, most patients with primary HPT should follow the Institute of Medicine guidelines for preoperative calcium intake. Preoperatively, patients who are vitamin D deficient can safely begin supplementation. Parathyroid FNA biopsy should be avoided. An additional voice evaluation should be performed if there is significant voice changes or prior at-risk surgery. Now, if one looks at the complications of parathyroid surgery, you're much better off getting it right the first time. There's a very low complication rate, very cost-effective management associated with success first time around. In reoperative settings, it's much different, as you can see the numbers here. Now, moving on to the initial surgery for sporadic primary HPT, we always think about either minimally invasive parathyroidectomy or bilateral exploration. We use MIP if we have single focus imaging results. We use bilateral exploration if there's a higher expected rate of multiglandular disease, such as in association with a positive family history, lithium, age, renal disease, or non-localized imaging. And we use bilateral exploration when there's concurrent thyroid disease and if intraoperative PTH is not available. The literature currently describes over 75 definitions of what is the definition of minimally invasive parathyroidectomy. From the standpoint of our guidelines, we would suggest that these include routine use of preoperative imaging, a short incision and focused dissection, and the increased use of adjuncts such as IOPTH. Endoscopic techniques are used more frequently in some countries as opposed to others. Bilateral neck exploration is still the gold standard, and it's used in cases of expected multiglandular disease. Planned bilateral exploration is preferred operative strategy in situations of discordant or non-localized preoperative imaging, when there is a high suspicion of multi-gland disease, when IOPTH is not available, or simply at the discretion and comfort of the surgeon. This is a typical positioning and incision for a minimally invasive parathyroidectomy. In our patient population in Minnesota and the Midwest, probably over half our patients are obese, and sometimes you have to adjust the length of that incision to the size of the patient. MIP is ideally used in patients who appear clinically and by imaging to have a single adenoma, and is not routinely recommended with a high risk of multi-gland disease. During MIP, conversion to a bilateral exploration should be prompted by the discovery of multi-gland disease, the inability to identify an abnormal gland, or the failure to achieve an appropriate drop in IOPTH. Bilateral exploration provides a time-tested standard of efficacy and safety in the definitive treatment of primary hyperparathyroidism. When available, intraoperative PTH monitoring substitutes a functional assessment for a visual assessment of adequate resection. When MIP is planned, intraoperative PTH is suggested to avoid higher operative failure rates. Surgeons who employ IOPTH sampling that is reliable in the local environment should be familiar with the interpretation and PTH decay dynamics. Both the Miami criterion and the dual criteria are effective protocols. Devascularized normal parathyroid tissue should be immediately autotransplanted. In patients with suggestive features of parathyroid carcinoma, this should be resected en bloc with the thyroid lobe and perhaps also the recurrent laryngeal nerve if involved, but no dissection and routine radiotherapy should be avoided, and patients should be followed long-term for recurrence. Postoperative management would include an operative report that is quite detailed to the pertinent events. Patients should be observed for hematoma. One should consider short-term calcium supplementation. One needs to evaluate for hypocalcemia and its symptoms, and calcium intake and vitamin D supplementation should follow Institute of Medicine guidelines. And this is just an example 3 months out from a minimally invasive parathyroidectomy with I consider a very nice scar. Finally, let's talk about postoperative management that includes diagnosis of cure and management of failure. Success equals a durable normalization of calcium at 6 months. Surgery for cure obligates the use of a validated technique to exclude or manage multiglandular disease. Proven to have high cure rates are bilateral exploration and MIP with intraoperative PTH monitoring. What is disproven or unproven is unilateral adenomectomy without IOPTH and all other imaging techniques, including probe radioguidance. We define cure as a normal calcium level at 6 or greater months. Initial postoperative levels may be misleading. The 6-month time point is also the accepted standard for determining persistence versus recurrence. Surgical cure, therefore, is defined by reestablishment of normal calcium homeostasis for at least 6 months. Failure is still the most common operative complication. In initial surgery, it's 1 to 5%. In reoperation, it's 5 to 15%. Reoperation thus has a higher clinical threshold. You need to have stones or osteoporosis or hypercalciuria the calcium should be greater than 12 milligrams per deciliter or the presence of a 30% reduction in GFR. Reoperation requires positive imaging and a preoperative vocal cord exam, and reoperation needs a greater surgeon experience. I won't go over all of this, but it is available in the guidelines. Hypoparathyroidism and recurrent laryngeal nerve paralysis cannot be truly determined until greater than or equal to 6 months after surgery. And we know also that parathyroidectomy surgeon volume inversely correlates with complications, cost, and length of stay. Surgeons should probably be doing about 50 cases a year to be considered experts in the area. Parathyroidectomy should be conducted by surgeons with adequate training and experience in management. Surgeons should choose an operative approach that in their hands carries a high cure rate. And patients with persistent or recurrent HPT should be evaluated by an experienced parathyroid surgeon prior to the decision to proceed with surgery or non-operative management. For the sake of time, I won't review the summary here, but we've reviewed it during the discussion, and all of this is available in the actual manuscript itself. Thank you for your attention.